We've all heard the phrase, it takes a village to raise a child. But the thing that we often forget is that it also takes one to support the mother.
Well, speaking of the village, this is our podcast. I'm Nicole Harlow.
And I'm Dawn Thompson. And we're here to connect you with a village of support you need from pregnancy to parenting.
So come on this journey with us as we build your village one episode at a time.
Hey, good morning. This is Dawn Thompson, and I'm here with my awesome co-host, Nicole Harlow. And we are here with Dr. Annette Fineberg today. And I'm super excited about this topic because, Annette, as you know, this is like a super passion project for me, and the craziness that is the 39-week induction thing that's happening since the wonderful, lovely Arrive trial. Let's just dive in. I mean, you don't need to give, I'll just say Annette is an obstetrician located here in California. And maybe you could just tell them why I invited you here and the research that you have just recently released.
Well, so after 25 years of practice, I actually went back and did a master's in public health. And in my practice, I had always been, I had always worked with midwives and doulas, and we had a very low C-section rate. We helped with the California Maternal Quality Care Collaborative process to make a toolkit to lower the cesarean rate, and a lot of that was based on and prevent unnecessary cesareans, and a lot of that was based on low intervention and not inducing. And so then when and there had been some studies before the Arrive trial. But when the Arrive trial came out and said that a 39-week induction, even if it was a first-time mom with an unfavorable cervix, actually resulted in much lower C-section rates, I have to say, I wasn't the only one, but I was kind of surprised by that because that wasn't my experience. Interestingly, I also had met the guy who did the Arrive trial, and actually he himself was kind of surprised by the results, and he wasn't expecting those results. And I actually asked him, I said, our team has lower rates than even the Arrive trial. Does this data even mean anything for us? And he's actually said no. But anyway, so in my master's project, I worked with Dr. Elliot Main, who's a high-risk obstetrician who's done a lot on C-section prevention. It's kind of my personal hero. Anyway, so I had an idea to look and see how the effect of the Arrive trial would be on a fairly high functioning team in Northern California. So that's kind of what we looked at, and we looked to see whether the Arrive trial would have a positive or negative effect on birth outcomes.
Well, I remember exactly where I was when I heard about the Arrive trial. Because I happened
Kennedy's getting shot. You
right.
Remember?
But I was at a major event, and I was in Copenhagen at the Women Deliver conference, and the docs had just been on the main stage at ACOG, and the feedback from that talk made it to Copenhagen very rapidly, as you can imagine. And I was standing there actually with the head of the Denmark's version of ACOG. I'm not sure what that is, but anyway, so just like the American College of Obstetricians and Gynecologists, this was the Denmark's version, and he was the current president of that. And so I said to him, what do you think about this? And I shared the information with him, and he just looked at me. He said, "Are they crazy?" He's like, "That's."
He's done a lot of 39-week inductions, knows that that's crazy. Because there are times when you have to when it's medically appropriate. And
right.
Any labor and delivery nurse knows that. Anybody knows that. And so, yeah, it was just kind of surprising. And interestingly, they tried to do the study I can't remember which European country. It might have been in the Netherlands or France, and they couldn't get consent for that. People wouldn't agree to it. So
well, and I mean that's one of the things that's been talked about this study exactly was that how many people didn't consent to the event or to the study.
Right. So the people that did consent were a very special group.
Right.
So yeah.
And I mean I think that there's been a lot of criticism about the research that way, but let's talk about why. I mean, it takes an average of, as we know, many things. It takes an average of 17 years for evidence to become practice. This caught on like wildfire.
Yeah, it did.
And were you at the meeting when they presented it? Do you remember?
2018. I might have been. I don't remember. I might have been actually, but I didn't go to the I don't remember being at the presentation.
Okay.
I'm pretty sure I was at ACOG though in 2018 or 2019 because I think I was presenting something other else,
Well,
Yeah.
what I'd heard was that they did a poll at the beginning to ask how many providers in the hall thought that people should be induced at 39 weeks. And of course, it was like 30% or something. It was 30 to 40%. And then by the end of the talk, it was over 70% when they repolled. And I thought, oh, no, this is not going to be good. And as a doula, I dreaded my clients getting an induction. After a couple of years in, you're just like, oh my God, if they go for an induction, it's going to be a C-section. And in fact, when they didn't end up in a C-section, I was shocked.
Mm-hmm.
Like, I remember just after a while, it was just like, this is a given. If you have an induction, we're doing a C-section.
I mean, I think the medications are better than they used to be, like from when I was in training, but still. And then also, I think part of the problem is that people get scared. I think once you scare a person, then they're willing to do whatever somebody recommends. And I understand that. You don't want it to happen to your baby.
Right. I mean, but I think it's unfortunate that we're doing. Can you speak to that though, Annette? Like, where is that fear coming from the provider? Like, I realize I want to be sensitive because I realize it's likely coming from their own trauma of negative outcomes or whatever, but it feels like it's extreme. And it feels like it's even coming from places that, like, even from providers who haven't lost any babies or haven't had this, they're still saying all the same things, like, oh, your baby's going to die if you go past 40 weeks,
Well,
like,
I mean, I don't know if people, I mean, maybe there are people who say that, but I think most people probably don't say that. They just say the rate is double or whatever. But then, the rate of stillbirth is about 1 in 1,000 at 41 weeks. And so if you're doubling that, it's still a pretty low rate. Not that every stillbirth isn't a horrible outcome,
right.
But you also have to think of what the mother has to go through sometimes.
Right.
Yeah.
Well, and the other thing that I always have said about research like this is that it only tracks the statistics and not the emotional part of the problem. You know what I mean? Like, yeah, sure. Okay. So that woman had a successful vaginal birth, but how did she feel about her birth? What was her experience? Is she totally traumatized? Is she, like, how did that play into her entire postpartum period? Because
the ARRIVE trial actually did look at that. They did. I mean, the people that chose to do it were pretty happy with it. I think they did look at whether they were happy with it or not. And I think they actually were happy with it. But again, that's a specific group of people who chose to be induced. So in defending them, they actually did look at that.
Mm-hmm. So, well, tell me what tell us what you guys wound up showing.
So we had kind of a natural history. We looked at two things. We had two things going on. We had this the CMQCC, the California Maternal Quality Care. We had this whole big rollout in the state of California to try to prevent unnecessary cesareans and lower, and lower the C-section rate. So it was a big rollout in the entire state of California. Many, many hospitals were involved, and it involved nurses and it involved processes of like when it was appropriate to do a C-section, like how many hours of being stuck and how to manage abnormal fetal heart tracing so you didn't race to C-section with the first decel, and when it was appropriate to go to C-section. And so we had that happen. That was rolled out in 2015. And then in 2018, the ARRIVE trial came out and the effects was pretty immediate, like the following year. So we had this, so the part of that CMQCC thing was a big database. it's collecting all the data on all the basically first time head down moms, babies head down, first
Right.
time full term, head down moms, when baby head down. So it's collecting all this data. We have two things going on. We have the CMQCC improvement, huge state improvement, and then we have the ARRIVE trial. So we looked at before and after 2018, and we looked at the rate of induction, which went way up. It was already on the way up, but it went way up after the ARRIVE trial. And then we looked at the rate of C-section before and after the ARRIVE trial. And we tried to make it fair. We tried to get rid of we tried to only have the very lowest risk women. We took out all of the women who had any type of diabetes, any type of high blood pressure, whether they were on medication or not. We had, let's see, I think we had all ages. We might have cut it off at 45, I think. But it was mostly every age. We cut off the body mass index at 50, which is pretty heavy. And let's see, I think that was, and then you had to be full term. You had to be after 37 weeks, before 42 weeks. And if the baby was less than 2,500 grams, which is considered growth restricted, or over 4,500 grams, which is very large, we didn't include those people. Because babies that are very small sometimes are more likely to have distress in labor. So we were really trying to keep as normal as possible. And we looked at the odds of C-section, controlling for all of those variables. And we did, while in both cases, the overall rate of C-section went down, both before and after the ARRIVE trial, but the odds of C-section with induction actually went up like 67% with induction.
Right.
So
That's a huge jump.
Yeah. So, I mean, I think labor was managed better. So, I mean, the overall C-section rate didn't go down, but it didn't, but I don't think we can attribute it to all that induction. I think we can attribute it to the improved labor management. That was what we thought from our paper.
Mm-hmm. Well, I mean, I think that I'm on TikTok, right? And I'm blown away at the amount of pregnant people that are just, I'm getting induced at 39 weeks. I'm getting induced. So my doctor won't let me go past my due date. And like, it was like, we saw this beautiful thing happening with Business of Being Born, which I think is 12 years old by now. But I remember when that came out, it really hit the market hard. And so many people started saying, oh, maybe we don't want to do an induction and we should be avoiding an induction. And it was like all this stuff was happening. And then the ARRIVE trial, it felt like we were making progress, and the C-section rate finally started going down for the first time in a long time. It's like we were seeing progress, and then all of a sudden that ARRIVE trial happened, and it just, boom. It was like as soon as it came out, I thought, oh, that's going to happen real quick, because it works for the system. Scheduling birth works for the system. Doing more works for the system. And it's really unfortunate. It's, and like I try to explain to people, I used to be really sort of negative about all of these things and pretty anti a lot of doctors, especially. But I've come around now that I've known so many obstetricians, and been able to sit and have real deep conversations about how hard it is to work in this system.
It is,
and manage it, and manage your liability, and manage your life, because we don't have enough doctors. So it's like, and how do we blame people for just trying to manage their lives? And it's really hard. And I get that now. And I think about the providers like you and Dr. Cap and Dr. Shavira, who I've been able to really have some great conversations with, and have them who are trying their damnedest to do what they know is right, but also barely on their feet most of the time because they're so exhausted.
Yeah, no, it is true. Although,
Right.
Inductions take forever and they're so unpredictable, and you still have that 3 a.m. delivery. So I don't know. I didn't,
Still
believe me,
didn't
if I thought they were better, maybe I would have, I just was not
Yeah.
experience.
But why don't you speak to that though, on like the challenges of being an obstetrician this day and age?
Well, I mean, I think it's, in some ways it's different. I mean, it's a lot different than it was, 40 years ago. Like, most people are covering with other people. So, but you're still up most of the night a lot of times for whatever, even if you're covering a group, you're up, for 24 to 36 hours. You're maybe covering GYN, you might be covering the ER. There's some high risk stuff. Even if you work with midwives, there's still, which I have always done for 25 years, there's still, even when they are very excellent and independent, there's still things that you need to be involved in that it's, and then there's two parts of a bad outcome. There's the horror that you go through personally, and then there's the aftermath, like either whether it's with the hospital, or then there's the part, if you end up getting sued. But even if you don't get sued, there's still just, it's not fun. I mean, I think anybody would say that it's really hard. You question everything about yourself, about your ability to be a doctor.
Yeah.
So you forget everything like wonderful and easy that happened for you. You only remember the really bad outcomes. So it's,
Right.
I think most obstetricians have been there, but I also think no matter how like avoidant you are, you're probably still going to get sued. So
Yeah. So talk to me about, though, I'd started to ask you about this, about like speaking to this, the fear and the, let me preface this with the fact that I hear all the time, like, you're the risk of stillbirth. I don't think you should go past your due date because the baby's going to get too big. And like all of the standard stuff that folks are being told every day. Like, how did we get here?
how did we get here? I don't know. I mean, I think there is a lot more fear in obstetricians that are being trained. I think depending on where you're trained, a lot of times you've not seen a lot of higher skilled stuff, and you actually, a lot of people actually think a C-section is better. So that's yeah, I think yeah, it's just it's been a big changeover since even just when I was a resident till now.
So why do they think C-section is better?
Well, I mean, there's different theories. People feel like, well, you usually have control over that one C-section. I mean, the truth of the matter is, a first C-section, even if the patient isn't super healthy, is pretty safe in this day and age. It's pretty safe. That doesn't mean that overall there aren't more, maternal morbidity and mortality. That means like bad outcomes and maternal death. But I think the first C-section is usually pretty safe, but it's the subsequent outcomes, your next pregnancy and the one after that is at a lot higher risk from a first C-section.
Yeah. And I think that's something, so for me, that's the thing, that I'm, standing on the hill for, is the fact that women are not being given all of the information to make these decisions. And also it's like, okay, so when you're talking about what's safe for that first C-section, for who?
Right.
For
And is
who?
it safer than natural physiological vaginal birth?
But
Well,
also,
a lot of OBs have never seen natural physiologic birth.
I would love to talk about that, because that's
I think they've never seen it. I hadn't seen much before I finished my training. I was really, really good about getting babies out if they needed it. Like, when on my training, we had a 90% epidural rate, and we all learned, I did over 100 forceps deliveries before I finished, but I had not really seen any kind of natural birth. I just didn't know what it was about. And then I learned that from working with midwives for 25 years. So that,
yeah.
So I think as I'm listening here, as a, mama four, as an observer of all these things that are happening in the world, right? I think it's what we talked about a little bit earlier, is the system. right? The system doesn't prepare OBs for good outcomes, only for bad outcomes. Then that inherent fear is, even if it's subconscious, is in the provider. And then that shared to the, the client, the mother, the woman, the family, because even the partner is there, right? And then it's easy to then all say, oh, less fear if it's controlled, whether that be for induction or C-section. But safe is a relative term there. I think safe in terms of you won't die or your baby won't die, but you're going to have a scar. You're going to have a harder recovery. You're going to have, again, more risk with more babies. And then also just, I know my sister had a C-section and, whatever happened to her scar, and then she had to go back and she had a growth restricted baby and preeclampsia, and she was dealing with all these things. And then all of a sudden her scar had oozing or something crazy, and she had to go back and get it, so with, my experience, I had a hospital birth, had an epidural. It was not traumatic. It was a great hospital birth. I had a great, nurse, great OB, nothing wrong at all. What drove me out of the hospital was really a postpartum decision, because I wanted a better postpartum experience, because I had a great birth. I was doing all the things postpartum. No one told me to stay in bed. It was my first baby. So I wound up giving birth at a birth center with an OB, with my second. And just that kind of just showed me, oh, wow, my body could do this by itself. And I don't think women are ever shown that. They're only shown or told the horror stories. And you just confirmed, doctor, you guys aren't shown safe, physiological, natural birth. I think and you as a woman is a very different empathetic experience too than a man, than, not witnessing or never witnessing a woman give birth naturally. At least you as a woman can see, oh wait, yeah, I know my body. It's magical, it's powerful, can do all these things, but a man can't technically empathize with that. So I think that's where it kind of stems from, if we're, trying to get to root cause here.
Yeah. Well, but also I want to talk about the fact that we rarely consider the long-term risks of a C-section. And again, that's one of the subjects that women are not informed on before they're making this decision of going the route of induction or going route of anything that increases the risk of C-section. Or even those who are like, forget it, I'm just going to go straight to C-section. But I've been dealing with major hip issues and really pelvic issues since my last couple, before my last two were born. And it's now coming to light that it is surgical adhesions that are attached to my pelvis that are making my pelvis constantly like this, and have now for decades. My oldest is 30 and she was my first cesarean. And, my third baby, I couldn't get out, even though I was doing home birth and attempting a VBAC after 3 C-sections or 2 C-sections. And it turned out that when I transferred to the hospital, went into the OR, thankfully the obstetrician was a good friend of mine. And he said he opened me up, and he said he'd never seen scarring like that ever, that it was like a melted box of crayons inside of me. And it was impeding even into my uterus, so that my baby wasn't being able to go down into the pelvis. And that was why I was not successful in having a VBAC. And so he spent 45 minutes and cleaned out all the scar tissue, and I was able to have my next baby vaginally. But the point is that I'm dealing with, I have major issues entirely on this side of my body where my pelvis is tilted all the time. I need to have a knee replacement. I've already had 2 procedures done to my knee. I have issues with my Achilles and my foot, and and I'm in chronic pain in my back all the time. And these are the things that when people are like, oh, C-section safe, that initial C-section is safe for who?
Yeah. Well, I mean, I think also like in, so I was born in 1965. I was born in a hospital and my mom had like twilight sleep. I was first baby. She was tiny. I was big. The doctor, she didn't even remember that he had used forceps to rotate me from posterior to anterior, pulled me out. And then that would never happen today. But that was a 3% C-section rate. He wasn't worried about getting sued. And then her next 3 babies came flying out easily, naturally. So like, I think people are very critical of that manner of care, and nobody would put up with that now. But, I'm not advocating for that. And I mean, I think in my training, like I said, we had a 90% C-section rate. If somebody pushed for 2 hours, we did forceps, but we had a very low C-section rate. Again, I don't think that's actually good care, but so now we're kind of where we don't do all these interventions, but then we also don't have the skills to get the babies out a lot of the time.
I just want to clarify, you said a 90% C-section rate, but you meant
90% epidural rate. No,
okay,
very low C-section rate.
Yeah.
We had an overall 15%, including like prior C-sections and everything. That was in the 91 or something like that.
Yeah, no, I get it. I mean, I think there's some things that we're doing better and some things we're doing far worse, right? Yeah. It's like, and it's like anything else. We always see the pendulum swing.
And I mean, we're older, the moms are old. We're older, we're heavier, we have more hypertension, diabetes. I mean, things have definitely changed since the 60s. My mom was 22. It's a very different situation.
Landscape.
But even like when we did this study, we controlled for all of that as best we could, and we found an increased odds of C-section. And this was in a hospital system that has a pretty low C-section rate. They did a pretty good job of trying to stick to the criteria of when to do a C-section, when not to do, as very good nursing, as very good teamwork. So, and that's not the case in every hospital, for sure.
Right. I mean, I think that's another thing that, when I think it was Adnan Labs, or Adnan, I never know how to say that word, with Neil Shah.
Mm-hmm.
And they were talking about, they wound up doing a study and determined that you're actually, the number one determining factor of whether or not you'll have a C-section is actually which hospital you walk into. Has nothing to do with you.
CMKCC too. That was Dr. Main looked at that a lot.
They did, yeah. And those are the things that I think. So
it was a huge variation. Like it was from 15% to 45%. I mean, that just with low risk full term moms. That wasn't even.
Yeah. Well, we saw some hospitals like in Florida, 60% C-section rate.
Yeah.
Like that's just bonkers. And that has nothing to do with the people around there. But I mean, I think I do agree with you in like, this will be a different topic for a different day, but I saw it in my practice as a doula. When I started in 2002, I on occasion would see preeclampsia on occasion. And then it was very sudden. And I don't know what it is. I hope somebody can figure it out, because it was like all of us in our community here, and we started talking about it because all of us were like, what is happening? It's like every other client has preeclampsia.
Well, the guidelines for when to intervene for preeclampsia have changed a lot in the last 10 or 15 years. We used to only intervene when it was really, truly preeclampsia. But now there's recommendations to intervene if there's any kind of slightly elevated blood pressure. And, you could argue back and forth about that. But that's, I don't know whether, I mean, it is associated, there's a higher rate of, if you're older, if you're real young, if you have hypertension already, if you have diabetes, if you're heavier, you have a higher chance. So that could be part of it. But also, we as obstetricians and midwives are intervening a lot earlier than we did, 10, 15 years ago. So
well,
maybe
but I mean, I was seeing it though, like physically, like I could tell. I could tell when my clients were developing, I could tell by just looking at their face whether or not preeclampsia was developing.
If they're putting like a lot of water weight on and stuff.
Yeah, like I could see it because, there's a difference between when people are getting, typical swelling in their hands, feet, ankles, things like that. But I could tell a preeclampsia face. I mean, I even saw a woman recently in the store, and I was like, she's got preeclampsia. And I thought I actually asked her, I said, you might want to go get your blood pressure checked. I'm like a random person, but I'm like, you need to go get your blood pressure checked, because what happens is I'm also ridiculously observant. It's just one of my superpowers, but I notice in their lips, if I spend a lot of time with them and like suddenly their lips look like they've been injected, there's something not right, so these are things that I notice. And then not to mention the super puffy face, but the lips is a big one.
That's one thing that's nice about a doula, because like a lot of times an OB is seeing somebody that they've never seen before. And so they don't really know what their normal face looks like. And so like a doula has met them a few times and has spent time with them. So you might really know you might be able to recognize something more different than
I've been the one that's set off the alarm bells many times as a doula. I've been the one who said, there's something not right. You need to go in and get your blood pressure checked, or even just go to the CVS. If she, she's like, I go to see her for her prenatal visit, and I'm like, there's something. let's get that checked out. So, but anyways, I mean, I think we've seen a lot. That's been a massive increase. But if you could have one thing that you would say to the consumer, so if a pregnant family is listening right now and their provider is recommending induction at 39 weeks, or they just have the expectation that they should be doing it because that's common, right? Everybody's like, oh, I'm getting induced at 39 weeks. Like that's what everybody's doing. What would you say to them?
I mean, I would say, I don't think you should be so afraid of induction in my career, we had a lot of people who were so afraid of it that even when it was medically indicated, they would really push back. And I understand that, but I think that there's definitely times when it's very advantageous to be induced. And so it's not like it's the end of the world. And we definitely have better medications and everything, but it's going to take longer for the most part. You're going to spend a lot of time in the hospital. You think it's just going to like zip, and it sometimes is if it's your third baby. But if it's your first baby, unless you're very, very lucky, it's going to take 2 or 3 days. And you probably, depending on who is inducing you, depending how patient they are, you may have a much higher rate of C-section, and you might just be begging for it because you're so sick of it. It's definitely the wrong choice if you're thinking you want an unmedicated birth. You will almost certainly have more pain. It's harder to handle the pain if you're trying for an unmedicated birth. That doesn't mean I haven't seen it happen. Like I've definitely seen people who need to be induced for whatever reason, and it's just if you're trying to add things up, I think before 41 weeks, I think you're really probably not making the right choice. That was my opinion, just having done this for 25 years. And even if you're willing to wait a couple more days, you might really, it's not that, because we used to actually go to 42 weeks, which I probably would have a hard time defending. But honestly, so many people go into labor at 41 and a half weeks that it's just a really large number. And you think it's not going to happen to you, but it often does. And I mean, it's the same thing like when your water breaks and you're not in labor. It's like my whole first, 10 years of practice or residency and my first 6 years of practice, so the first 10 years, we always checked people right away and started inducing them. And I can't even tell you how many C-sections we did. They almost all got infected. And, when I was in Davis, we never examined them and we waited. And, 80% of people go into their own labor in 24 hours and they would come in booming away, 6, 7 centimeters and do great. And we would wait, 24, 48, even up to 72 hours. And they often did very, very well. And because we were very fanatical about not examining them, they did very well. So I would say if your water breaks, don't let somebody examine you.
Right. Okay. So yes.
But not with their hands.
Yes. So, but what you're saying is so powerful because you just demonstrated why one hospital might be better than the other. You just demonstrated it, and how because still all the time, people whose water breaks, they immediately go running to the hospital. They're getting vaginal exams in most cases, and they're being told that they have to get the baby out and start induction within 24 hours. When actually that is not the best course of action.
The baby's head down, the water's clear. They can go home and take a temperature. They can just not put anything in there if they're low risk. I mean, obviously, if the baby's not in a very good position, if the baby's, not head down directly, or, the fluid's not clear, or, whatever, if their blood pressure is high, there might be lots of reasons why you don't want to do that. But there's also lots of situations where you can just wait a little.
Sure. And I think that that's most cases, it's like, and I think that's the other thing that's difficult for people to navigate is, what is medical necessity? What actually qualifies? Because frequently their big baby is given as a reason for induction, when that is not actually a true medical indication, unless the baby is really
well, and the ultrasounds are pretty inaccurate. They can be plus or minus a pound or more. And you also don't know what size baby is going to fit through a certain person's pelvis. My mom is 5'3" and probably 110 pounds when she was full term, and I was 8'3". I mean, so you just, and so the ultrasound could have said that baby, I was 10 pounds. So you just don't know until you really try. Now, maybe if you, actually, one of my favorite studies is was done at USC, LA County, where they used to have just like thousands and thousands of births, and they had so many births they couldn't really even keep track of things, as far as I could tell. I was never there, but one of my favorite studies was they looked at what babies who had an estimated fetal weight of over 4,500 grams. So that's big. That's like 10 pounds. And they, this was, who knows how accurate that ultrasound was. I think it was done probably in the early 90s or something. And they had people, and they basically, they didn't induce them. They didn't start Pitocin if they petered out. They didn't pull the babies out unless it was like right there or something and they really needed to for distress. They basically just like let nature take its course. And the vast majority of them delivered fine without shoulder dystocias, without the baby getting stuck. And some of them went to C-section, but like, I've always kind of, I read that right when I first went into practice, and I've always kind of used that, like, okay, don't push it. You're not going to pull that kid out. But, some of these, I've had patients who are like, 5'10", 5'11", and their husband is huge. They're Norwegian, and they say, oh, the baby's big. It's like, big surprise, the baby's big. Like, what are you thinking? This is not like a little Peruvian woman.
Right.
I have a friend.
Big, Scandinavian couple, they're going to have a big baby. It's okay.
Right. I have a friend who's she's just under 6 feet. Her husband is well over 6 feet, and her smallest baby, I think, was 9 something. Her largest was 12 pounds, but like, of course it was, because, and then I'm 5'3", my husband's 5'10", maybe 5'11" on a good day. And we had, 7, our one was 9 pounds. I don't believe he still was 9 pounds. It was our birth center birth, and I don't think the scale was super calibrated there. He was probably high 8s. He's definitely our chunk now, but it's all relative, right? And I think also it's important, what you said was just like, there's so many factors in every situation and every person and every different birth, right? So we have to be aware of all of the things, but realistically, it comes down to the individual experience. And I think that's what we're lacking today as well, is like the autonomy and the education to the moms to say, all of this could happen, but all of it doesn't have to. Let's look at you specifically, and not, yes, there's obviously statistics and there's obviously like the norm, but as you were saying with the water breaking, two of my kids, my water leaked and it never actually broke until they were all coming out. But I was dripping fluid for a day or two with my last, and my midwife, was actually during a snowstorm, so she wound up sleeping over because she didn't want to drive the hour back just for me to be like, hey, I'm really in labor now. But she was taking my temperature, and just making sure everything was good, and it wound up being fine. But I think that's a really, big piece I want to make our listeners aware of is like, there's all the things that can go right. There's all the things that can go wrong. There's all the factors that will determine those outcomes, but know yourself, know your body, have these conversations with the provider, and, kind of determine that path that's right for you. Not, oh, everyone's doing a 39-week induction, I want to get on that bandwagon. Oh, my entire family line had C-sections, I want to get on that bandwagon. Like, no, let's just be ourselves.
Individualized
Right?
care.
Yeah. Well, the other thing that I would add is that, doing a third trimester ultrasound is independently associated with a C-section, no matter whether the baby is actually big or small, because we all get scared as, you think, oh my God, that baby's big, I better not be more patient. But also, like, unless you need a third trimester ultrasound, and I don't mean just a 36-week check, is the baby head down or not, that I would recommend. But in terms of like a size ultrasound, unless the baby's measuring really small in the clinic or measuring really big, because maybe it might not, because it might not be big, but maybe it's a massive amount of fluid and not a big baby. I mean, unless there's something really indicates a third trimester ultrasound, it's probably not necessary unless you have other risk factors. I mean, there's times when it's absolutely necessary, it's absolutely indicated, but the more information you have, the more wrong information you can have, and the more wrong information, the more likely we are to intervene, because we all get scared. We want the best outcome. And when we have that information, we're all going to act the same way because that's what we're taught to do. But yeah, that's what I would say.
So that of course just brings me to the other thing that's commonly given for a reason for induction, and that's low amniotic fluid. Mm-hmm. And I actually got into a pretty heated debate with an obstetrician on TikTok about this, because she said, you're giving dangerous information because you're saying that low amniotic fluid is not indicated for, is not a true medical indication. And she was correct in the way that I said it was inappropriate. That yes, but she totes herself as the evidence-based obstetrician. And so I challenged her on this fact, because I said to her, like, well, okay, so you're right. I said that incorrectly, because it would be a medical indication if it was accurate.
And right. Well, that's the thing is, why did you check it? And like, what was the indication for checking the fluid? Was she after 41 weeks? Was she growth restricted? And how did you check it? Did you use the deepest vertical pocket, or did you do an AFI? Because the deepest vertical pocket is more likely to not give you a false.
Right. Well, so she and I went back and forth about it, because I was like, but it's being overdiagnosed, and it's being it's driving people to C-section and da da da. And I said, it's so rare. And she's like, it's not rare. Like the actual,
it's not rare after 41 weeks. But it's right. But it means nothing at like 37 weeks with no indication. It's just, was she dehydrated? Was there a reason? If the baby's normal size and the fluid is a little low at 37 weeks, why was it even checked? And can you recheck it unless it's really, really low?
Right. So then we went into the discussion of, and she's like, well, it's not that rare. And I was like, well, but how often do you see it in your practice? And she said, we induce labor at 20% of the time every month for low amniotic fluid. And I said, then you're part of the problem. I did. I just was like, I don't know who's doing your ultrasounds, because I said, who, then you're part of the problem. Someone is,
especially if it's before 41 weeks. If it's after 41 weeks, okay, I can understand 20% have low fluid, but
right. But they're inducing well before then. So anyway, so I just was like, you're part of the problem. If that's the number that you're telling me is coming out of your practice every month, then that you're part of the problem. And so I said, you cannot claim yourself as evidence-based, because clearly you're following an ultrasound, anyways. So it's things like that women are battling against. Like, how do you even manage that? Like, you want to trust this medical professional who went to school, right? It's like the thing I hate about what I do is that I often instill mistrust in the care providers.
Right. And the danger of that is, like, I feel like as a group we have instilled mistrust. And then I've also seen situations where I or somebody else really needed the patient to trust me, like this baby really is in trouble, and they didn't. And that is a heartbreaking situation.
Yeah.
Like, you guys are always lying to us. I don't believe you. And then, their baby really did need to be born, and they
Well,
didn't.
it's like the boy who cried wolf, right?
Right. And I think that that's a really tragic situation, because I've definitely seen that a couple times in my career.
Yeah. I mean, I've seen it too. Even in my situation where I've had to been like, oh no, listen, this is the time. This is when we need to do it. But their initial indication was like, no, I don't, like, I don't want, this is not what I want. And I think people being flexible, but the problem is this overuse of interventions in general is just out of control. And now when people really need it, it's not well, I mean, the problem is that the majority of people are just like, yep, I'm getting my induction. I'm so excited. In our beta test for Birthify, we had 20 people. 17 of them were hospital births. All 17 were encouraged to induce labor at 39 weeks, all of them. And not a single one of them had a medical indication.
Really? Wow. That's really, really high. I don't think we're having that high level up in NorCal, but I think, I don't think that that's been our standard, but that's pretty alarming.
It is.
So
and if you go into any pregnancy group, though, on Facebook or go on TikTok, all the influencers are getting induced at 39 weeks there. I mean, like, it is frightening to me.
So the reason why, what inspired me to do the study that I did was that there was another study after the ARRIVE trial, done by Gilroy, where they used just birth certificate data. So it wasn't a randomized controlled study, but they used birth certificate data for the whole country. So it was like 1.5 million people.
Mm-hmm.
And they did see a very slightly decreased, well, they first of all saw a huge increase in induction both before but a big increase after the ARRIVE trial. But they also saw a slight decrease in C-section rate, but it was really minimal. Like, it was statistically significant, but that in a huge group like that, it's very easy to be, it doesn't have to be a big change, but it was still way more than the C-section. I think it was a much higher C-section rate than the ARRIVE trial. The ARRIVE trial had an unusually low C-section rate, both in the induced and non-induced. But anyway, so they had a tiny bit lower C-section rate, but it was really not clinically significant. But what alarmed me was they actually had a higher outcome of higher rate of bad outcomes for the mother and the baby. So that worried me. We actually didn't see that. We didn't see like more blood transfusions or more NICU admissions, but they did in that study. So that's kind of what concerned me.
Yeah, I mean, I guess, when we start talking about other factors that are impacting us as a whole in humanity, of course, it seems like you said, we're having high preeclampsia, higher diabetes, higher, rates of all those things. And of course, that would contribute to, different outcomes and more need for intervention. But
actually, I'm going to correct that. The Gilroy trial showed an increased poor outcomes in the mother, I believe. That was what concerned me. I think the babies were the same.
Okay.
So, yeah.
Okay. Well, Nicole, why don't you ask your question?
Yeah, of course. So, Dr. Fineberg, speaking of the village, besides an obstetrician, who would you say is the most important role in a woman's village?
Well, I've definitely seen where doulas were the most important thing, but honestly, I think that in terms of like C-section prevention and probably the immediate postpartum, I think the labor and delivery nurses can have a huge impact. They can make or break it. They can say things that be like, oh, you better get your epidural because you might need it later and they won't be here, or like, oh, they can just make it. But they can also be the person who, when you've had a really bad situation, they can be the one who debriefs it with you and maybe makes the difference between you having postpartum depression and not, or just being able to deal with it. So I would say that a really good labor and delivery nurse is just really, really important. And
Annette, thank you so much for being on today. We really appreciate it. And, this subject matter is near and dear to my heart. And I hope that anybody who's listening, really understands that there is a lot to consider before going into induction of labor very casually, because there are tremendous amount of risks, especially if you really don't want a C-section. And understanding that, like, as we talked about, C-section is a big deal. It's not something to be taken lightly. Like, a lot of people will be like, I don't care if my risk of induction increases my C-section risk. It's fine. Like, whatever, if I have a C-section, but there's a lot to understand about what that means. And I hope that we did a great job today of helping people understand it more. Yeah. Well, thank you so much for the information, and we appreciate you a lot. Thanks.
All right. Have a good day. Thanks.
Thanks. Hey, thanks for joining us on Speaking of the Village. If you love today's episode, make sure to hit subscribe and share it with a friend.
And remember, you're not alone. We're here, we're listening, and we're all in this together, because in our village, no mom walks alone.